Thank you. So, thank you, everybody. I hope the course so far is going well. The topic for the presentation that I have been asked to focus on is the use of ultrasound in the management of multiple gestations. So, primarily, what we're going to be talking about are twin pregnancies. I'm not going to be talking about higher order multiples, triplets, quadruplets, and so forth, because of course they're relatively rare. The majority of what you're going to be seeing and managing are your twin pregnancies. So again, really honored to be here. So thank you very much for the invite. Please let me know if at any point you wish to stop, ask questions, or if I've not been clear on any particular topic. So the outline for today's presentation is really just to cover the theory behind the use of ultrasound in the management of twin pregnancies. I'll have one slide on background. This is not new information for yourselves. I'm sure it's all very familiar. And then talk about ultrasound in the context of early pregnancy, so where it's used to determine chronicity, to date the pregnancy, and also how to manage those where you see there's a discordant nuchal or a discordant CRL. Ultrasound in the second and third trimester. So in this part of the pregnancy, you're looking at sort of just routine surveillance in your uncomplicated twin pregnancy, and of course where complications arise, as they frequently do, and how that changes matters. So twin pregnancies, very common, particularly in Nigeria, as you said, twin capital of the world. And with that, obviously, comes a significant amount of perinatal and maternal mortality, and of course, morbidity as well. In comparison to singleton pregnancies, dichorionic, monochorionic pregnancies, much more likely to result in a preterm birth, much more likely to have complications like fetal growth restriction, much more likely to result in a fetal demise of either one or both pregnancies. And of course, to the mother, we see complications like diabetes, preeclampsia, eclampsia, and complications around birth, such as bleeding, much more frequently in this cohort of patients. So really a group that we need to be very careful with and monitor very closely. So we're going to start off with the first trimester. And of course, what you're trying to determine in the first trimester is how many weeks pregnant, what is the chronicity. I think this is probably the most important, because it really does help to set the course for the rest of the pregnancy as to how you're going to manage them, and what to do when you see a discordance in certain anatomical features that we look for. So very basic. I'm sure this is familiar, the terminology to all of you here. Chronicity obviously refers to the number of placentas. Zygosity refers to your number of zygotes. In other words, are the twins identical? And of course, really to have an understanding of the difference between the two and how that impacts on pregnancy, you need to be reminded a little bit on the sort of proposed model of twinning. And again, this is very basic and probably very well known to you, but I'll cover it quickly. So diazygotic twins are essentially two separate fertilization events that have happened, resulting in non-identical twins. They've got two separate placentas, and they're known as dichorionic, diamniotic, and as a result, this pair of twins are identified by what we call the lambda sign or the twin peak sign, which is seen here. For those who were on the basic course, this is probably all very familiar. I covered it in the presentation last week, but I'll go through it quickly in this presentation as well. So what you can see here is this sort of thickened area where you've got placental tissue highlighted by the red star in between the two twin membranes. And as I said, this is what we call the lambda sign of a DCDA pregnancy. When you see this, you know that it's dichorionic. Conversely, your monozygotic twins result from post-zygotic splitting. So you have a single fertilization event and splitting that occurs in the post-zygotic period results in your monozygotic twin pregnancies. And depending on the stage at which they split really determines the type of monozygotic pregnancy that you have. So when the splitting occurs early, between days 1 to 3, then again, you end up with a dichorionic, diamniotic twin pregnancy. So again, that's your lambda sign seen here. However, when the splitting occurs just a little bit later, so between days 3 to 8, then you end up with a monochorionic, diamniotic twin pregnancy. And this is identified here by your T sign. So unlike with your dichorionic pregnancies, where you've got that thick placental tissue, you can see here that you don't have that thick placental tissue. You've got this sort of thin, wispy intertwin membrane, and of course a single placental mass. Later down the line, so this is split in after after day 6. So now you're sort of up to around day 8, day 13. And if this happens and you get your monochorionic, monoamniotic twin pregnancies, so again, a single placental mass, single sac, so you have no intertwin membrane at all. And what I haven't shown here, but what is exceptionally rare, are your conjoined twins, and this occurs when your splitting happens after day 18. So how do you determine chorionicity via transabdominal ultrasound if the woman presents to you after 14 weeks, as they often do? Of course, we know that chorionicity is best determined in the first trimester, but this will not, of course, be the case in many circumstances where you have women rocking up much later in pregnancy. Transvaginal ultrasound can sometimes be more sensitive in the latter gestation, so you can always attempt this. Of course, looking at the fetal gender. So if you have a boy and a girl, then of course, this is a dichorionic diamniotic pregnancy. The number of placental masses can also sometimes be helpful. However, it's important to recognize that in many dichorionic pregnancies, the placenta can be very close together and therefore appear as a single mass. And actually, although I don't quite understand the mechanism by which this happens, in about 3% of monochorionic twin pregnancies, you can have 2 placental masses. So the recommendation is not really to rely on this as a way of being able to determine chorionicity. And then if all else fails, so if you really don't know, because TVS has not added any information, it's same fetal gender, both twins, then really it's always safer to assume that the pregnancy is monochorionic and treat it as such, because of the implications of not. So we've determined our chorionicity, and now moving on to dating the pregnancy. Now, again, this is familiar territory. I covered this last week, but just as a refresher, the way that we date the pregnancy is between 10 up until around 14 weeks gestation. This is the period, the window in which you're able to provide the most accurate date of the pregnancy. And of course, the way that we do that is by measuring the crown rump length in order to give an accurate gestational age. This is the section that you're trying to obtain. It's a mid-sagittal view of the whole fetus. You're trying to get the baby as horizontal as possible, really optimize your image. So bring it into the center of the screen, occupying the whole width of your screen. You want the chin in the neutral position, so not too flexed, not too hyperextended, because then you either under or overestimate your CRL, and then you're taking the longest length from the head or the crown all the way down to the rump or the bottom of the fetus. Now, in the context of a twin pregnancy, then of course what you are using is the largest CRL. So you're measuring 2 CRLs. The CRL that you'll use in order to establish the EDD is the largest CRL that you can obtain. And the reason why we do that is because if you use the smallest one, then you're more likely to try and determine that the baby is large for gestational age later in the pregnancy, resulting in unnecessary intervention. So the largest CRL is used to be able to date the pregnancy in the context of a multiple pregnancy. Okay, but there are other ways to date. And again, I've covered this already, but traditionally it's always been on the last menstrual period in women who have regular cycles. We don't tend to recommend or use this in most scenarios. However, failing other methods, if the woman has regular cycles, then potentially can be used. Assisted reproduction, we don't redate the pregnancy. So whatever date they've been given from the timing of their treatment is a date that sticks with them throughout the pregnancy, irrespective of what your CRL is. And of course, in those that are later in gestation, so in those that present to you essentially after 13 plus 6 weeks with a CRL that's greater than 84 millimeters, we use a head circumference as a way of dating the pregnancy. And again, in a multiple pregnancy, what you'll be using is the largest head circumference in order to give you that date. So what happens when you have a discordance in either the nuchal translucency or the CRL? And what that means is that you have one twin that has a completely normal nuchal translucency of 3.5 or less, and you have another twin that has a completely abnormal nuchal translucency of 5 or 6. Now, there's been many studies that have tried to determine the predictive value of a discordant nuchal translucency for adverse pregnancy outcomes, such as fetal demise, such as twin-to-twin transfusion in monochorionic pregnancies, and so forth. And the same for CRL. Again, if you have one twin that is appropriately sized and you have another twin that's very small, what are the implications of that in a monochorionic pregnancy? Now, the data is conflicting, but the cutoffs that seem to have the most amount of sensitivity is if you use 20% for nuchal translucency. So if there's a discordancy of 20% or more, then that seems to be fairly accurate at being able to predict the risk of complications in that pregnancy, namely fetal demise and severe twin-to-twin transfusion. So you can see that just looking at the biggest study, the risk of fetal demise and severe twin-to-twin transfusion in pregnancies that had a discordant nuchal of 20% or more was around 30%. If you move over to the right, if you look at those that had a discordant CRL of 10% or more, then again, the risk of complications like early fetal demise, preterm labor, fetal growth restriction occurred in just over half of these pregnancies. The other implication of having a slightly small CRL in comparison to the other twin in early pregnancy is that actually the risk of chromosomal abnormalities is much higher. So really, the bottom line is that when you see this in early pregnancy, discordant NT or 20% or more, a discordant CRL of 10% or more, then these are high-risk pregnancies for complications, including fetal demise, including TTTS, but also you need to do a very close anatomical survey, either in early pregnancy or later, if that's your comfort zone, in order to determine if there are structural abnormalities elsewhere to indicate a possible chromosomal condition. And obviously, where available, where applicable, offer the option of invasive testing. And that's what's emphasized here. So moving on to labeling, we've spoken about data in the pregnancy, we've spoken about chorionicity. So how do you label the pregnancy? Quite often, this can be a source of general confusion, which is twin 1, which is twin 2, which is a presenting twin, et cetera, et cetera. And really, if you look at the literature, if you look at the guidelines from various different international, national communities, there are so many different protocols that have been recommended. I think what's important is to identify the protocol within your unit and essentially stick with that one. And really, there's not any definite strength from one protocol to the other. So we'll go through a few that have been proposed. One protocol, one method of labeling the twins is on the basis of the placenta. Now, obviously, this is of limited value because the position of the placenta will change with advancing gestation. And so really, this technique is not applicable, whether it's a monochorionic or a fused dichorionic where you've got that sort of single placental mass. So we don't tend to go on the basis of placental masses. The other option is to look at the position of the twin in relation to the cervix. This can quite easily be done in early pregnancy. Again, the problem with this is that this, again, can change with advancing gestation, and it quite often does. So really what we tend to do and tend to recommend, because it seems to be the most reliable, is that we look at the position of the gestational sac in relation to the cervix. So not the baby, not the placenta, but the gestational sac in relation to the cervix. And this is really in the earlier gestation, so before sort of 16 weeks, where you're able to do this most accurately. And based on the position of the sac, we determine which twin is right, which twin is left, or where the intertwin membrane is lying horizontally across, which twin is lower, which twin is upper. And this is the most reproducible because the position of the gestational sac in relation to the cervix remains the same throughout the pregnancy, unlike the position of the placenta, unlike the position of the baby itself. But I think, you know, like I said, in addition to really just establishing within your institution what the best method is, so everybody's singing from the same hymn book, so to speak, is really to use as many other descriptors in your reports as you can. So typically when I'm writing a report for twin pregnancy, I'll describe the gender where there's discordancy. So twin A is male fetus, breech on maternal right with a posterior placenta and a marginal cord insertion. So as many descriptors that I can put in there to really identify which twin that I'm speaking about. So then again, if it's not me, the next time that's scanning this patient, I can look for all of these features and say, okay, I know which twin I'm scanning, and it's the same from one scan to the next. Same with twin B, female fetus, cephalic, on maternal left, anterior placenta. So it's not necessarily relying on any one, but just, as I said, putting in as many descriptors as you can. If you are going to rely on one, then certainly the position of the sac is probably the most reliable. And then I think, you know, we always have to alert the parents that actually, even if you label the twins, twin A, twin B, then there's a 60% risk of what we call perinatal switch. And this happens most frequently at the time of birth, and essentially means that, you know, what you think is your twin A might not be your twin A at birth, might in fact be your twin B. This is particularly important when you have discordant anomalies. So, for example, if you have one baby that's got a congenital diaphragmatic hernia who needs, you know, immediate attention, immediate intubation following birth, then they're not, for obvious reasons, it's important that we identify and know which baby is which. Okay, so routine surveillance. This is now, you know, I completely appreciate that the pathway is going to differ from one country to the next, from one institution to the next. This is the pathway that is most often recommended in the surveillance of uncomplicated dichorionic pregnancies. So we see them generally early, between 11 to 14 weeks. During that scan, obviously, we date the pregnancy using the largest CRL. We label according to the gestational sac and the position of the gestational sac to the placenta, to the cervix, sorry. Determining your chronicity is the most important factor. Quite often we get referrals from other institutions where they've not been able to determine chronicity, in which case we will look at other features and try and see if we can do so. But as I said, the safest option is always to assume it's monochorionic if we're not able to determine the chronicity for whatever reason. And your anatomy scan becomes even more important in the context of any discordancy with regards to the nuchal translucency or the CRL. We then see them again, as with a singleton pregnancy, between 20 to 22 weeks. And the purpose of that scan, again, is to look at your anatomy in perhaps a bit more detail, perform your biometry, perform a cervical length. These are the recommendations. Obviously, there's a lot of controversy as to, in the context of a short cervix, what do you do with a twin pregnancy? But nonetheless, we measure the cervical length and we measure the amniotic fluid volume. And then from that stage onwards, we scan them monthly, so every 4 weeks. And again, this is in the context of an uncomplicated pregnancy, where we perform Dopplers, so your umbilical, your middle cerebral artery Dopplers, your ductus, and we perform biometry, and also we assess the amniotic fluid volume. And this occurs until birth, which is typically between 37 and 38 weeks for all dichorionic pregnancies. Monochorionics obviously require much closer surveillance. So again, this is an uncomplicated monochorionic pregnancy in the pathway that we tend to follow. So as with the dichorionics, we see them early, between 11 to 14 weeks, to date the pregnancy, to label, and that labeling will stick throughout the pregnancy to determine chronicity and to look at anatomy. Just to go back to labeling, I think, as you know, having scanned many multiple pregnancies, I spend a lot of time actually making sure that I have the correct baby. I spend a lot of time getting my orientation, and I spend a lot of time looking for those factors which help to identify one or the other. The reason being is because we've all been in a situation where you 45 minutes down the line have performed your scan and are then confused as to which twin is which on the basis of the previous source scans going forth. This also becomes much more relevant when you're scanning higher order multiples. So as I said, triplets, quadruplets, and last week we scanned quintuplets, which is exhausting exercise. So with the monochorionics, we see them around 16 weeks, and then again at 18 weeks. And really, we're seeing them every 2 weeks from then on. Between 16 weeks and 18 weeks, we're performing biometry at this really early gestation. We're assessing the deepest vertical pocket. So although I said amniotic fluid volume on the previous slides, obviously in multiple pregnancies, you're assessing your deepest vertical pocket, not your amniotic fluid index. And I'm measuring the umbilical artery PI, and I'll go through in subsequent slides how I measure the umbilical in twins. So after 18 weeks, we see them again at 20 weeks, same thing as before, except this time, again, we're looking at the anatomy and we're measuring the cervix. And then from 20 weeks, we scan them every 2 weeks. This is, as I said, in uncomplicated pregnancies, where we look at the biometry, we measure the deepest vertical pocket, and we measure the umbilical Doppler and the MCA to look at the peak systolic velocity. And that's until delivery, which routinely takes place between 36 and 37 weeks. So that's your routine management of twin pregnancies. What about the not so routine management? So when you see complications like selective growth restriction, twin-to-twin transfusion, twin anemia polycythemia syndrome, twin reverse arterial perfusion sequence, and when you have a neutrophytal demise of a monochorionic twin, how does that change what you do and how frequently you scan these patients, what you're looking for? And so I'm hoping to go through each of these individually and talk a little bit about the ultrasound markers that we tend to look for. So starting with selective growth restriction. The most commonly used definition for selective growth restriction is when one fetus has an estimated fetal weight below the 10th centile. Many clinicians require the addition of there being an intertwin estimated fetal weight discrepancy of greater than 25%. So that's one twin being less than the 10th centile. And in addition to that, you've got a discordancy between the two of 25% or more. The reason why a lot of clinicians add in this estimated fetal weight discordancy is because, well, actually, if both twins are on the 10th centile, then this is likely a baby which is likely babies that are constitutionally small rather than a pathological problem. Now, the risk of fetal growth restriction in monochorionic pregnancies is much higher. It's around 20%. In dichorionic pregnancies, the risk of fetal growth restriction is around 10%, which is not too dissimilar from your singleton pregnancies. Now, how do you estimate your estimated fetal weight discordance? I'm sure many of us are familiar with this, but essentially you deduct the weight of the smaller twin from the weight of the larger twin. You multiply by 100 and divide by the weight of the larger twin. And we calculate and document this at each scan. Now, 25%, again, where has this number come from? There's been a lot of studies over the years to try and determine the cutoff threshold for estimated fetal weight discordancy that we should be looking at. 25% seems to be the one that is associated with the highest level of perinatal morbidity. However, saying that, really, if you have any monochorionic pregnancy with an estimated fetal weight discrepancy of 20% or more, these are high-risk pregnancies and need to be closely monitored. So if we look at the classification and management of selective growth restriction, and obviously this differs depending on whether you have a dichorionic or monochorionic pregnancy. So I'll start off with just the dichorionic twins. So you've scanned the patient, you've recognized that it's met the criteria for selective growth restriction. One of the babies has an estimated fetal weight of below the 10th centile, and there's a discordancy in the estimated fetal weights of more than 25% between both twins. Now, the Dopplers are normal, so you've checked the umbilical artery, you checked the ductus venosus, you checked the middle cerebral artery, and all of the Dopplers are normal. So it's just growth at the moment, which is a problem. In these pregnancies, it's perfectly acceptable to monitor them at fortnightly intervals as long as those parameters remain normal. So as long as your umbilical remains normal, your ductus remains normal, you can scan them every 2 weeks. So rather than scanning them 4 weekly, like I showed you in the previous slide for the uncomplicated pregnancies, in this pregnancy, because one twin is small, there's a discordancy of 25% or more, you're going to scan them minimum fortnightly. And at each scan, you're assessing the biometry, you're documenting the discordancy, you're documenting the deepest vertical pocket for each twin, and you're looking at the Dopplers, which would include your umbilical, your ductus, and your MCA. However, when do you need to scan them more frequently? When do you need to think about delivery earlier? Well, I mean, essentially, the management for fetal growth restriction in your dichorionic pregnancies follows the same algorithm as what we follow for singleton pregnancies. And this is based on data from a randomized controlled trial called Truffle, the results of which was published a number of years ago. And essentially what that means is that, again, you've scanned the baby, you've identified that one is below the 10th centile, your discordancy is more than 25%. However, here you have Doppler abnormalities. So how do your Doppler abnormalities guide the timing of delivery? If the baby is less than 32 weeks, then really the only indication for delivery is if your ductus becomes abnormal. So if your A wave of the ductus venosus becomes either negative or absent. And you can see that in the picture below. This is an example of a ductus venosus A wave, which is negative. So at that point, you know that your baby is pre-terminal. It needs to be delivered because the risk of IUD in this baby is very high. So before 32 weeks, the indication for delivery in a growth-restricted dichorionic pregnancy is a change in your ductus A wave. So what about later? So we move on to the middle column, the orange column. You've got between 32 and 34 weeks. What Doppler changes are you waiting for in order to determine whether or not you need to deliver your pregnancy? In this cohort of patients, you're looking for reversed end diastolic flow in your umbilical artery. So your indication for delivery within this window is reversed end diastolic flow in the umbilical artery. And again, you can see that in the picture here. You've got reversed flow. You can see that nicely all throughout your wave sequence. And then finally, the green box, what is the indication? You're waiting for absent end diastolic flow in your umbilical artery. Okay, so these are the indications. Before 32 weeks, ductus changes. Between 32 and 34 weeks, reversed end diastolic flow in your umbilical artery. And between 34 and 36 weeks, you're looking for absent end diastolic flow in the umbilical artery. And as I said, this is how we manage our fetal growth restriction in singletons. If you only have growth as your issue and your Dopplers remain normal throughout, then we tend to deliver these babies at around 37 weeks as we would in a normal dichorionic pregnancy. I hope that's clear. So if the delivery criteria is not met, but you have Doppler abnormalities in a dichorionic pregnancy where there is selective growth restriction, then the duration at which you need to be scanning these pregnancies is much more frequent, and we tend to recommend alternate days rather than every 2 weeks as previously shown. Now, obviously, like I said, there's going to be some flexibility from one unit to the next, but I guess the bottom line here that we really want to emphasize is that if you have a growth-restricted fetus in a dichorionic pregnancy and you have Doppler abnormalities, then they need to be closely observed. Now, the other tool that you can, of course, use is your CTG. At UCLH, we use a computerized CTG, and we base delivery criteria on what we call the short-term variability, which is a indicator of fetal acidosis. But if you don't have computerized CTG, then of course, if you have CTG abnormalities at any point, irrespective of what your Dopplers are doing, then this would be an additional criteria to deliver those babies sooner rather than later, because the risk of fetal demise here would be quite high. And I think what we need to be aware of, we know that maternal preeclampsia is much more common in twin pregnancies, but if you have growth restriction affecting that pregnancy, then the risk is significantly higher, in that up to around half of these women will eventually develop preeclampsia. And of course, your indication for delivery then might not be so much the baby, but actually the mother's well-being that determines the need for delivery. So it's not just looking after the twins, scanning the twins and making sure that they're stable, but also reviewing the mother and making sure that she hasn't developed preeclampsia in the meantime. What about more monochorionic? So you spent a lot of time talking about dichorionic, but of course your monochorionic are perhaps a much more risky type of twin pregnancies. And basically the classification of selective growth restriction in your monochorionic pregnancies is dependent on the pattern of end diastolic flow in your umbilical artery. So in type 1, you can see that your umbilical artery has positive end diastolic flow. So the point at which you reach diastole is above the baseline. Now, the risk of mortality here, so the risk of the growth-restricted twin dying is quite low. It's between 2 to 4%. The risk of neurological sequelae in that growth-restricted twin, again, is quite low. It's around 4%. And in this situation where you have elevated resistance within the umbilical, but still positive end diastolic flow, surveillance is advised at least weekly. So you're scanning these patients at least weekly. Now, in terms of delivery, remember in your uncomplicated monochorionic twins, we deliver them routinely between 36 and 37 weeks. In this scenario, you're scanning them at least weekly with the view that you're going to deliver them at around 35 weeks, irrespective of what your Dopplers or your growth are doing at this gestation. Type 2 is a slightly different picture. Now, in type 2, you have absent or reversed end diastolic flow. Now, you can see the difference between type 1 and type 2. What they've done here in type 2 is that they've reduced down the speed at which they're measuring the umbilical waveform. So you can see that within that sort of excerpt, you've got many more waves compared to the type 1. And the reason why they do that is because what they're trying to exclude is type 3, which I'll show you on the next slide. So type 2, you've got absent or reversed end diastolic flow persistently in your umbilical artery. You can see here this in the picture very clearly. Your mortality in these pregnancies of the growth-restricted twin is about 30%. The risk of neurological sequelae in life is much higher. It's around 14%, sorry. And because the risk of mortality here is quite high, the risk of deterioration here is quite high, we recommend that rather than scanning them weekly, possibly you need to scan them a little bit more frequently, but of course this is going to be a case-by-case basis. So once to twice weekly is really the duration at which we tend to scan them, with the view that we deliver these babies prior to 30 weeks because of the high risk of mortality. Now, actually, if you look at the case series on selective growth restriction in monochorionic twins, most of these pregnancies, bar 1 or 2, get beyond 30 weeks. This is a type of selective growth restriction which carries the most degree of risk. These babies are not going to go much beyond this gestation because the Dopplers are just going to become so abnormal that you have to deliver them because of the risk of spontaneous fetal demise. So what about type 3? Type 3 is where you have cyclical or intermittent pattern of absent or reversed end diastolic flow. And you can see that here in the picture. So at the beginning, there's reversed end diastolic flow. Moving towards the end, you've got absent end diastolic flow, but no longer reversed. And the reason why this happens is because of the anastomoses, which are within the single placenta mass of the monochorionic pregnancy, that you get this sort of cyclical pattern of Doppler changes. Now, again, the risk of mortality here is quite high. It's between 10 to 20%. The risk of neurological sequelae is much higher, and that's in the surviving twin, so not the growth-restricted twin. It's about 20%. And the rate at which you need to monitor them via ultrasound is similar to your type 2, once to twice weekly, with a view to delivering them around 32 weeks. The reason why we recommend delivery in this group, of all the types of selective growth restriction, what I would say is that the risk of death in type 3 tends to be much more unpredictable, in that it doesn't tend to follow the same sort of classic pattern of growth restriction that either your dichorionic or your type 1 and type 2s tend to follow. With type 3, where you have this cyclical change in the umbilicals, as I said, the death in that growth-restricted twin can be very sudden and sort of difficult to sort of foresee. And of course, and I'll cover this later in the slides, the implications of death in a monochorionic pregnancy can be significant. So how do we manage them? What do you do? Well, if it's type 1, then we manage them expectantly. So again, as I said, we just scan them weekly with the view to delivering them slightly earlier. If it's type 2 or 3, really this is very complicated. And actually, having worked in this unit for a number of years, it really is a discussion that we will have with the patients as to what the best way forward is for them. Depending on the gestation, of course, sometimes you might decide that delivery is the best option. On some occasions, we've opted to proceed with what we call fetoscopic laser ablation of these anastomoses. The problem with this modality of treatment in the context of selective fetal growth restriction is that, if you can imagine, the reason one twin is smaller than the other is because they have a much smaller share of the placenta. And so they're reliant on these anastomoses that are going from one side to the other to survive. If you then ablate the anastomoses completely and essentially dichorionize the placenta, then you're reducing the share of the placenta that growth restricted baby has by an even bigger amount. Ultimately, it tends to result in fetal death of the growth restricted fetus rather than to help the situation. Sometimes parents find that it is one way of opting for what we call a selective termination, so reducing the pregnancy to a singleton without having to make that decision. But as I said, management of type 2 and type 3 is a very complex discussion that's often had with the parents and not very easy to manage. The other aspect to mention is in terms of latency period. Now, if you are thinking about a singleton or dichorionic pregnancy and you notice that there are changes in the umbilical artery, then what we call the latency period, which is a period between which you have identified that Doppler abnormality and birth, is usually in the region of about 4 to 5 weeks. What we know with monochorionic pregnancies is actually that latency period from when you have Doppler abnormalities to birth tends to be much longer, tends to be in the region of around 10 weeks. However, those Doppler abnormalities occur much earlier in the pregnancy than with your dichorionic or your singleton. Okay, so what I mean by that is that you'll have a growth restricted monochorionic twin with an umbilical artery Doppler abnormality at 20 or 24 weeks, rather than 28 weeks in a singleton or dichorionic. But they tend to go on a bit longer. So moving on to twin transfusion syndrome, I'm sure we're all familiar with this and what it involves. This occurs in between 10 to 15% of monochorionic pregnancies. I should say monochorionic diamniotic pregnancies, because we don't see it so much in monochorionic monoamniotic pregnancies. And essentially is as a result of these anastomoses that are highlighted in the placenta here. So you can see the white arrow at the bottom is sort of just pointing to an arteriovenous, quite a large arteriovenous anastomosis, the presence of which obviously results in this hemodynamic distribution between the two twins, causing an amniotic fluid imbalance, and many other changes that we often see on ultrasound. Now, the classification is typically described using the Quintero criteria. So stage 1 is where you have the presence of polyhydramnios or oligohydramnios sequence. So you've got a deepest vertical pocket of 8 or more in the recipient and a deepest vertical pocket of less than 2 in the donor. Stage 2 is when the bladder in the donor twin becomes no longer visible. Stage 3 is when you start to get Doppler abnormalities with absent or reversed umbilical end diastolic flow, or abnormalities in your ductus, for example, all of which indicate progression in the twin-to-twin transfusion. Stage 4 is when you start to get high drops in one or both twins. And stage 5 is when you've got fetal demise of one or both twins. Sorry, let me just go to participants and mute. Okay. So how do those different stages look on ultrasound? So you can see that on stage 1, you've got presence of both bladders. So you can see that the recipient bladder is at the bottom. It's maybe looking a little bit what we call polyuric, so a little bit enlarged. The donor bladder at the top is present, maybe slightly smaller, but certainly present. You can see it. Now, in stage 1, what you tend to see is a little bit of this membrane folding. So I don't know if you can sort of kind of gather that this sort of membrane is rather than it being sort of nice and wispy and free flowing, it's starting to sort of invert on itself. And typically we see that in pregnancies which are developing stage 1, that are developing twin transfusion. Now, quite often we have what we call this sort of pre-stage twin transfusion syndrome, where you have a discordancy in the amniotic fluid volume between the two twin sacs. This doesn't necessarily fulfill your criteria for stage 1, but identifies those that might possibly evolve to full-blown twin transfusion. And as I said, just need closer monitoring. So stage 1, you've got this membrane folding, you've got this discordancy, 8 centimeters in one, 2 centimeters in the other, but both bladders are visible. Moving on to stage 2, again, you can see that the recipient has huge amounts of amniotic fluid surrounding themselves, and the donor is sort of stuck off to the top that you can see here. The donor bladder, you can't see anymore. The recipient bladder, you can. And again, it's just looking slightly polyuric, where it's just a little bit enlarged. Stage 3 is where you start to get your Doppler abnormalities. So you can see that there's reverse flow in the umbilical Doppler, or you've got reverse flow in your A wave for the ductus. And stage 4, again, as I said, you can see the development of ascites or other features of hydrops in your recipient twin. And of course, stage 5, which I haven't shown here, is fetal demise of one or both. So I guess the reason what I wanted to sort of just put this slide in is that it's not always immediately obvious how to measure the umbilical artery in twins, because again, what's important is that you have reproducibility. So from one scan to the next, everybody's measuring the same parts of the umbilical cord. Now in singletons, obviously you're looking for a free loop, but in twins, it's sometimes a little bit difficult to determine who that loop belongs to. And so what we tend to do, or what I tend to do, is measure at the level of the bladder. So I apply my color Doppler on the level of the bladder. You can see here that you can see the umbilical arteries, but actually you can't see the bladder in between. So this is a stage 2 at least, and this is where I Doppler. Now, what you're probably going to identify is that the resistance is slightly higher when you measure the umbilical artery at this level. But as I said, it's about consistency. So every time you come back and you measure, you're measuring at the same place, and you know that's a fact. The other place to measure is at the level of the abdominal insertion, which again is another reproducible way of being able to know that 1, you're sampling the correct twin, and 2, you're sampling the same place every time you scan that patient. So really, ultimately, it doesn't matter, but it's just to make sure that you pick one and that you're consistent with where you sample. Now I sort of focused, I spoke about this before, because what you want to rule out, if you can imagine when you measure the umbilical, if you only have 4 or 5 waves, what you're not going to be able to identify is your stage 3 in your monochorionic. So your stage 3 fetal growth restriction in your monochorionic pregnancies. And so what you really want to do is reduce that speed right down, so you get lots of waves in one picture, and then you can determine, are there any cyclical changes in my umbilical which would identify a baby that has stage 3 fetal growth restriction. Now, in terms of management, we know from many studies that actually we don't tend to intervene with fetoscopic laser with stage 1. It's expectant management, but you have to monitor them quite carefully. In about 60% of those with stage 1, they will remain completely stable. They won't progress to stage 2. They'll have uncomplicated births, healthy babies. From stage 2 onwards, however, the mortality does increase to the point where if you do nothing, it's about 90% or more. And in terms of what you can do, at UCLH, obviously, we do the laser ablations of the fetal anastomoses, and this is performed after 16 weeks. In other centers, however, it's perfectly acceptable to offer a serial amnia reduction if the pregnancy is more than 26 weeks, as a way of trying to maintain the pregnancy further. And the way in which this works is obviously trying to impact the hemodynamic circulation, which is ongoing and really fueling the condition. And of course, selective termination is always something that will be discussed more in the context of much more severe twin-to-twin transfusion syndrome. So follow-up post-treatment. So in those that have had serial amnion reductions or in those where they've had laser, really for the first couple of weeks, you need to monitor them still quite closely every week. And if everything remains stable, then they can be monitored every 2 weeks until birth. Now, they need close anatomical surveillance because any intervention that you do for twin-to-twin transfusion can result in limb reduction implications. There can also be cardiac changes that occur as a result of twin-to-twin transfusion. So it's about looking at the whole of both babies throughout the pregnancy to try and identify any of those. And again, irrespective of how these pregnancies do following your treatment, we do tend to deliver them a little bit earlier, around between 34 and 35 weeks. So moving on to TAPS or twin anemia polycythemia sequence. Again, this is caused by anastomoses, but unlike with your twin-to-twin transfusion, it's caused by much smaller anastomoses. So you have a much sort of slower transfusion process. This occurs in about 5% of monochorionic pregnancies spontaneously, but actually we see it post laser ablation for twin-to-twin transfusion in about sort of 13 to 14%. Now, the diagnosis is based on your MCA, and this is why you measure your MCA in your monochorionic pregnancies, because what you're really interested in is your peak systolic velocity. And essentially what you get is a discordancy between the MCA PSV in the anemic twin and the MCA PSV in the polycythemic twin. So what you can see here is you've got two twins. In one twin, the MCA is 41. In the other twin, the MCA PSV is much lower, 19. Now, we calculate the multiples of the expected median, and this can be done using an online tool through perinatology.com. So in one, you've got a MOMS of 1.66, and in the other, you've got a MOMS of 0.78. If you have this degree of discordancy, so if you have an MCA PSV of 1.5 or more in one twin and an MCA PSV of less than 1 in the other, this by definition identifies your pregnancies, your monochorionic pregnancies that have developed TAPS. If the MCA PSV is greater than 1.5, you've got an anemic twin. If the MCA PSV is less than 1, then it's sort of sticky, cloggy blood, then your velocity is much slower. This is a polycythemic twin. Other ways to identify TAPS is that obviously you have this MCA abnormality, but you've got normal LICOR, you've got normal bladders in both twins. And you can also look for differences in the appearance of the placenta, which you can see here. So the donor twin, so this is the anemic twin, has a really sort of bright echogenic placenta. It's very sort of thick, whereas the recipient twin, so this is your polycythemic twin, has a sort of very thin and much more sort of echolucent placenta. The other way of being able to identify TAPS, and again, if I see this MCA discordancy, the first thing that I'm going to look at is really the liver, sorry, because again, in the bladder, keep saying the bladder and the liver or the polycythemic twin, you have this sort of what we call this starry sky. So you've got all these sort of echogenic flecks in the liver as a result of emboli from the polycythemia. So in terms of prognosis, if it's severe, then generally speaking, both twins are at fairly high risk of death. In the context of TAPS, and generally speaking, the anemic twin will require blood transfusion following birth, and the polycythemic twin is highly likely to need an exchange transfusion. The risk of sensorineural deafness, and this can be severe, is around 13% in the donor, and the risk of developmental delay in both is around sort of 20%. So that's your prognosis. And in terms of management, again, this can be very difficult to manage. Generally, it occurs much later than twin-to-twin transfusion, in which case we tend to just recommend delivery. So moving on to TRAP sequence, this is a very rare complication of monochorionic twin pregnancies. It occurs in about 1% of monochorionic twin pregnancies, and in the general population, it occurs in about 1 in 35,000 pregnancies. So it's very, very rare. And essentially, it's characterized by the presence of an acardiac mass that you can see here. which is perfused by an apparently completely normal twin, which is sort of called the pump twin, and that's sort of seen in the image. Now, the perfusion basically occurs in this retrograde fashion through these huge arterial anastomoses. Usually the cord insertion site, as you can see here, is common or very close together. Now, this ultimately results in this very hyperdynamic circulation where you have the pump twin, which is spurning out all of this blood and perfusion towards the acardiac twin. And essentially it leads to them developing high cardiac failure and ultimately high drops. So when you see this, you have two options. One option is that you can say, well, we're going to do nothing. We're just going to scan and continue to monitor, looking for any signs of high output cardiac failure. The problem with this is that the risk of demise in your sort of healthy twin is quite high. It's reported as around sort of 50%. So the other option, which we tend to almost always recommend, is interruption of the acardiac twin circulation. And the way that we do that is a number of different mechanisms or processes have been recorded. At UCLH, we use radiofrequency ablation of the umbilical cord. And this is usually performed earlier in the pregnancy, before 16 weeks. But as I said, there are lots of different techniques around the United Kingdom, elsewhere in the world, called umbilical cord coagulation, umbilical cord ligation, and so on and so forth. But ultimately, they all do the same thing: interrupting blood flow to the acardiac twin to save the pump twin. And this improves survival to more than 90% of the pump twin. So we've spoken a lot about the possibility of fetal demise. In dichorionic pregnancies, this really, the only impact of a in utero fetal demise in a dichorionic pregnancy is it does tend to increase your risk of preterm labor. The possibility and the implications of fetal demise in a monochorionic twin pregnancy, because of the shared placental circulation, is obviously much higher. So when you do have spontaneous demise of a monochorionic twin, what are the implications to the surviving twin? There's about a 15% risk of death if the surviving twin, if the twin survives. Then in life, there's about a 25% risk of severe neurological injury, and that can typically be seen either by detailed neurosonography later in the pregnancy or by MRI. And your risk of preterm birth increases significantly as well when you have a single twin demise. Now, generally speaking, how do you manage these pregnancies? If you are seeing a woman, they've come in, you've scanned them, you realize that one twin has died, then generally speaking, if the surviving twin has not died within the first day or two, then they are going to survive. The other indicator that you might read a lot about in the literature is looking at the MCA-PSV. So again, the peak systolic index. And the reason why this is important is because, of course, when the twin dies, you get this massive transfusion of blood from the surviving twin that results in a drop in their blood pressure and a drop in cerebral perfusion. And this would be indicated in your MCA. Some feel that if your MCA is normal, again, within the first few days from when that twin has died, then actually this is a good predictor that that twin is going to be okay. There are other features that you can look for. Of course, you can look for ventricular megaly as an indicator of intracranial hemorrhage or other cerebral abnormalities. And porencephaly, this is a picture to the left at the bottom with the green stars, where you can see this huge degradation in the white matter of the brain. Now, generally speaking, if you're going to see these abnormalities, it's not going to be immediately around the time of death of the monochorionic twin, but will be 4 to 6 weeks later, which is why you cannot discuss too much about the potential for neurological injury in the surviving twin until that 4 to 6 weeks has passed, because that's when the neurological sequelae will become most evident. So what do you do? If they're term, then obviously you consider delivery of the surviving twin. But if they're preterm, then it doesn't make sense to deliver the surviving twin, because ultimately whatever has happened has happened. And so in addition to the possible insult of that twin dying, you add in the additional challenge of prematurity. And so usually you recommend conservative management, evaluating the MCA-PSV, If you have access to fetal MRI, then obviously we recommend this as a much more sensitive source of imaging 4 to 6 weeks down the line. Or alternatively, it's just about performing comprehensive neurosonography to try and determine if there has been any sort of neurological sequelae as a result of single twin demise in a monochorionic pregnancy. So there's a lot of information. We've spoken about early pregnancy and what we're looking for in early pregnancy, chronicity, dating, labeling, and what you do when you have a discordance NT or CRL. What are the implications of that finding on the risk in that pregnancy? We've spoken about second and third trimester, and we've gone through all of the different complications that happen, particularly in monochorionic pregnancy, which is really your highest risk pregnancy. And then finally, we've spoken about demise of a monochorionic twin, and the implications of the surviving twin, both immediately and in the longer term. So it's a lot of information. I hope that has been useful and covered the curriculum and what was needed.
Thank you very much, Jane. As usual, your lectures are very loaded.
Yeah.
Yeah, well, we're glad to have them. And obviously means I will go through them over and over and over again. But we're extremely grateful for the amount of information that you have given unto us. And it also shows the depth of your experience and practice. Please, another round of applause for her.
Thank you very much. It's really a pleasure to be here.
Thank you. So, questions, please.